Well, I have the pleasure of introducing our first speaker. Dr. Vaccaro. Professor Vaccaro is the Richard Rothman Professor and Chairman in the Department of Orthopedic Surgery, as well as the Department of Neurosurgery at Thomas Jefferson University in Philadelphia. He has served as the president of the Rothman Institute there since 2014. Dr. Vaccaro graduated from Boston College, and I'm going to leave that date undisclosed. Graduated from Boston College. He attended medical school at Georgetown and then completed his internship at Cedars-Sinai before completing a residency at Thomas Jefferson University. Dr. Vaccaro then completed his spine fellowship at the University of California, San Diego, and earned a PhD subsequently in the field of spinal trauma and an MBA in 2015 at Temple University. Dr. Vaccaro has been the recipient of numerous awards and honors over the years, and he really is someone who needs no introduction here. He's had an immeasurable impact on our body of knowledge in spine surgery. He's authored more than 900 peer-reviewed papers and over 370 book chapters, and has edited more than 60 textbooks. He's also served as the past president of the Cervical Spine Research Society, the American Spinal Injury Association, and the Association for Collaborative Spine Research. Without further ado, Dr. Vaccaro.
I just want to say what an honor it is to be here. So number one, I don't have a mask. I'm sitting there going, oh my God, I need a mask. So I apologize. And I have COVID right now. That's a joke. That's a joke. No, I don't have COVID. But I'll tell you a funny COVID story. I was flying to the ISAS meeting a couple weeks ago with my family. We have a loving family. We love each other dearly. So I took my in-laws. I paid for everybody. We get the suite at the hotel, and we're getting on, and we had to get tested in the airport. And I tested positive. My family didn't even notice I wasn't on the plane until 2 days later. So I never went, actually. That's a true story. I never went to the meeting. My family went without me. So I was asked to talk about sports injuries, and I've been the team doctor for the Eagles since 2004. Who loves the Eagles out there? Nobody loves we got one Eagle fan. We're the worst fans. You know, you're lucky I don't come over and beat you up right now, because that's what happens. Steelers, all right. So I used to I'm from New York, so my dad would come down and I'd say, Dad, just do me a favor, don't wear a Giants uniform in the stadium, because they will actually beat you up. And he's like, oh, no, that's not true. I go, this is true story, they've killed fans from the other team in the parking lot. It happens in Philadelphia. And every game, my dad would watch people get beaten up. So we have a really good fan base overall. So I wanted to talk about what we know about return to play criteria, what my feelings are, my experience. I end up operating on 4 or 5 of these athletes a year, and then the stress you have from the owner, from the GM, from the player, from the agent. So it's an interesting cocktail of things that we deal with. So my conflict is that I'm a team doctor. So this is an interesting website that looks at cervical spine injuries, and looks at every year. It says, where do these injuries come from? And they look at everything that's going on. And I remember as a trauma surgeon, when I was young, I said, okay, I'm never going to ride a motorcycle, because you see some motorcycle injuries. I go, it's not going to happen. Guess what I will not do today as a 60-year-old man? Ride a bicycle in the city. So if you look at the statistics, everyone my age gets murdered on a bicycle. Todd Albert, my partner, got hit right in front of the hospital and was hospitalized for about a week. So bicycles are dangerous for men as we get older, and especially making a car's making a right-hand turn, you're in the right lane going forward. But those are the breakdowns of the injuries as we see them, and the vast majority of sporting injuries, unfortunately, happen to the cervical spine. When I played football, I had a lot of concussions. I had a lot of neck sprains. I had a herniated disc in my neck, and it's very common that we see those injuries. So this is sort of like an overview. If you could just press the video button. If you can go back and press that video button right there. This is the worst. This has nothing to do with a cervical spine injury, but it's the worst. I had to put that in there. I think this is the last one, thank God. So it's interesting, in almost every sport except marbles have I seen a cervical spine injury. And I've seen some pretty bad injuries. Every single sport, hockey, lacrosse, you see injuries. So it happens everywhere. So it's important to understand they can happen. What are the mechanisms of why they happen? Treating them surgically is the easiest part of managing a cervical spine injury. The most difficult thing is to get the athlete back in shape and then allow them to go back. And I'm thinking as I speak to you now, like the headaches. I just recently was on the phone with a mother of an athlete, and this athlete was probably the third top pick for the NFL coming out of college. And it was someone that no one in this room would clear for surgery. And the mother was ripping me one because he had the potential to get a $20 million deal once he got out. And I was like, listen, I treat every player that like they're my family member, and I would never let your son go back because it's such high risk. And I remember the mother just screaming at me about how I'm taking this livelihood away from the child. So we have to keep that in mind. And these are just the statistics. 44% of all spinal injuries will occur in the cervical spine. The exposure, 148, that's every time an athlete makes contact, 148.26 per 100,000 athletic exposures in the professional world. So it's something that we see quite frequently. And this is one of the reasons why we see, if you could play that video, why we have cervical spine injuries. Because the athlete makes the mistake of dropping their head. So it's like anything else. You can't spear. That's common. I can tell if an athlete spears by looking at their plain x-rays over a career. If you look at Dickinson, who played for the Colts, and again, I'm going to date you my age, but Dickinson was one of the greatest Colts running back ever, and you couldn't stop him, but he had one bad habit. He used to put his head down. And you have a running back putting their head down, you can't stop him, and it's dangerous for you because he injures you as a linebacker or the defensive halfback. But over time, they develop a kyphosis, and it's called the spear-tackler spine. And if we document that as a team physician, that they have a tendency to drop their head, and they cannot be insured. So insurance companies in the NFL said, we're not insuring them because they have a propensity to get injuries. So we have to keep that in mind. So we teach everyone in the sports, if you can play that video, to keep your head up. Hit with your shoulder, hit with the side of the neck, and that's a perfect tackle. Now, that slide below is an actual picture taken when the helmet was first invented. And they said, listen, it's a bad idea not to have a helmet. They literally advertised it as, with this helmet, look what you can do. And that was, if you look at the original advertisements for a football helmet, and that's how dangerous it was. Now, the other thing that's interesting, and I've seen this happen before, if you're a linebacker and a defensive lineman and you tend to put your head down, it's almost like the aged. Like we so often see in 70 and 80-year-olds cervical stenosis where it's worse at the C2-3 level. Same thing happens in athletes. If you look at the combine and if you look at the epidemiology of the injuries that we see, it's somehow, however they hit, when they hit inappropriately, they tend to herniate a disc higher up in the cervical spine rather than C5, 6, and C6, 7, which I think is interesting. Now, one of the scariest things is if you have an injury to your spinal cord. Now, Torg confused the literature. Torg was in Philadelphia, and he said, don't worry. If you have a cervical spinal cord neuropraxia, there's no statistical reason why you may have a catastrophic, so you can go back to play. And he said that multiple times, and he wrote about 6 papers. But if you really look at the papers and you look at what we know today, is that's not really true. If you have cervical stenosis, God forbid you have myelomalacia, and we look at stenosis, we look at 13 millimeters being the borderline, 10 being absolute, 10 millimeters space available for the cord. If you have significant stenosis, the chances of having a secondary cervical spinal cord neuropraxia or a permanent increases significantly. So these are the things that we have to look at. Now, My partner, Greg Schroeder, when he was in Chicago at Northwestern, had the opportunity to look at the whole collection of combine imaging studies to say exactly what these athletes have. And we now have to do those examinations, and it's a wealth of information. Every single football player will get an MRI of the cervical spine when you enter the NFL. And it's interesting if you look at the collection, and these are the athletes, and what he found was a lot of these athletes have critical stenosis, a lot of the athletes may have myelomalacia and have been asymptomatic. And there's nothing worse than a superstar college athlete having an occipital C1 assimilation, a C1, C2 assimilation, spinal cord myelomalacia, and they never knew it. And right there in the combine, they find out for the first time, and their career is over. So it happens. And if you look at the outcome of those that had previous spinal surgeries, those that has things that are unusual, and you follow them over time, there's no difference in career longevity as long as they haven't had a spinal cord injury. So having a problem in the neck, having a fusion is not a problem. And I'm going to go through a Delphi survey we did at the Cervical Spine Research where we looked at all the questions that you have. Like I know as a team doctor, I go, well, what would you do in this situation? What would you? And again, which brings me up to SIG. Every time I have a crazy deformity case, I send it to SIG. I go, SIG, what do you think? We have the same type of network among all the team doctors, all the spine surgeons. Every time we have some crazy case, we send it out for 3 reasons. Number 1, to let people know these things happen. Number 2, to learn. And number 3, to cover ourselves medical legally. So we said, listen, I talked to 15 spine surgeons for different clubs, and this is how we would go about dealing with it. And if you look at if we have to operate, and we operate quite frequently, you have a significant cervical disc herniation, and does not get better. A lot of these players are having surgery now, and now you can see the NHL. How many cervical disc arthroplasties have been performed so far in the NHL as of yesterday? Was that 5? 5. After that guy from Colorado did the first case, everyone's getting a cervical disc arthroplasty. So it'll be interesting to see how it turns out over time. But you can go back and you can have a very, very fruitful career. Now, the weird things is, what do you deal when you have someone that has myelomalacia? Now, again, when I first started this job, if I saw bruising in the spinal cord, that would be like a red flag. I mean, that can't happen. But that can resolve. You can do follow-up MRI scans. If people don't have stenosis or critical stenosis, those players can go back to play. And there hasn't been anything significantly noted in terms of their follow-up. But if you look at people, regardless if they went back to play or not, and they had critical stenosis, 60% of them will have a problem. Therefore, you have to be very careful. Cervical spinal cord neuropraxia with critical stenosis, with or without myelomalacia, has been reported to increase the risk of having a significant neurologic deficit. So these questions up here, these are the questions I get every day from football players, from rugby players, from hockey players. What can I do to protect myself? And a lot of these players, and I still remember looking at some of these MRIs, some of the veterans having a ribbon spinal cord of stenosis in the setting of kyphosis. So these are the questions people ask me. Can I protect myself? Does my position matter? If I have a disc herniation, I get better. Can I go back to play? If I have surgery, can I go back to play? What are my predisposing risk factors? So I'm going to show you level 3 and level 4 data because there's no level 1 data. We don't do any controlled prospective randomized studies. This is all level 3 and level 4. This is the best paper published today, systematic review by Failings and Associates, looking at the world's literature, and they put it all together. And when it came to the questions that you and I have, number 1, if you have a cervical spinal cord injury and you get better and you have no stenosis, well, you can go back to play. There's only been 1 documented case of someone having, without stenosis, a recurrent cervical spine neuropraxia. Now, if you have 7 studies that said if you have stenosis, there has been multiple case reports of people having permanent neurologic deficits going back to play and get it injured, which is interesting. Having an anterior cervical decompression or fusion. I recently did one at the C5-6 level. The coach had this player who's a great running back. Coach had the player on the receiving team for the Eagles. He went down, carried the ball, put his head down, couldn't move his arms or legs. I remember running out to the field, and I'm like, oh my God, there must have been a catastrophic failure with my surgery. And the surgery was like a year before. He herniated above the fusion. So it can happen. And then what are the predictors? Well, if you have someone that has a prolonged symptomatic period of not being able to move their arms or legs, if they're younger, if they have a ratio where there's significant stenosis, these are the predisposing factors that we look at. So let's look at return to play. Let's get into the complicated questions. Now, the vast majority of athletes who are cared for surgically can go back to play. And those are the odds. So you could tell your athlete, listen, as long as you go back, as long as you don't have the things I'm going to talk about in a few minutes, you can go back and play in a contact sports. This was one of the original articles that really went into depth, Wang's article in 2016. Here's a few things I disagree with, and I outlined it below. So the three things you have to have if you're going to let someone go back to play, even on the sidelines, they have to be asymptomatic, no significant neck pain, full range of motion, and no neurologic deficit. Now, if you go down further, he writes it's an absolute contraindication to play with a 2-level anterior cervical fusion. So that's not true. We let 2-level anterior cervical fusions go back to play in the NFL. It's called a relative contraindication. And you know what a relative contraindication means? It means how much money they make. And they make a lot of money, they're going to go back and play football. And that's exactly what happens. But it's not an absolute contraindication to play. And the other thing that's a little bit of a question mark is pseudoarthrosis. Now, a friend of mine, and again, I'm just going to throw these anecdotal stories. You have a stable pseudoarthrosis. What is the risk factor? The risk factor is pain. It's not a catastrophic neurologic deficit, not a neurologic deficit. And a friend of mine allowed one of the players in Carolina to return back to play with a pseudoarthrosis. He had worsening neck pain. He then sued my friend. Another friend of mine who was an NFL team was the expert against him. And on the way to the trial, he had a heart attack and died, the doctor. Does anyone know that case? You guys don't pay attention to the gossip in the team physician. So I'm always worried about so I personally have a little trick when I do an anterior cervical decompression and fusion. I don't like to use allograft bone alone because allograft can take 8 or 9 months to look solid. Because, they're just not coming back to see you. They're seeing 7 other team doctors. I like to use an interbody spacer, and I take core of the iliac crest bone graft, and I place it inside the interbody spacer. It always heals by 4 months. So you can let a professional athlete go back to play contact football at 6 months. If their alignment, a quarterback can go back at 4 months. If you do it that way. If you use an allograft bone, it always takes like 8 months for it to look solid. And if it doesn't look solid, someone's going to throw stones at you. So that's something I disagree with. So this was just a review we did years ago. And we looked at all the different questions. So I outlined absolute contraindications to play. You get a cervical spinal cord injury, you have myelomalacia, and you continue to have stenosis, you're not playing football again. You're not wrestling, you're not going back to any contact sports. And then the other things are just commonsensical, persistent symptoms, anything with an occipital fusion. And again, the woman that I had the argument with on the phone just recently, her son had an occipital C1 assimilation, and then had a C2-3 Klippel and then had a 3-4 and herniated 2-3. She had an occipital C2 assimilation. They were all fused. She was opened up at 2-3, herniated at 2-3. It's just crazy. And I was like, no, you can't play football. And had surgery at 2-3, did not heal the fusion at 2-3, and had absolute stenosis less than 10 millimeters of spinal canal. I mean, it was like a checklist of everything on that slide, and we had it out. So that makes sense. Now, relative contraindications to play means nothing. It means they're playing if they're motivated. It means they're not playing if they're in high school. It means they're probably not playing if they're in college. But if they're getting paid $50 million a year, they're playing football. 2-level fusions, we let go back. And pseudoarthrosis, there's no reason why a pseudoarthrosis that's not at risk for a catastrophic neurology should not be able to play. But it's a legal risk for you if you let them go back to play, because their neck pain is probably going to get worse. Because everyone has neck pain, and they'll come back and throw stones at you. But we have to write that more. And then no contraindications to play. If you do not have stenosis, you do not have myelomalacia, you have total resolution of your symptoms, and a single-level fusion. Single-level Klippel doesn't matter unless it's an occipital C1 or C1, C2. So now for the interesting questions. This is where it gets interesting. So, at the Cervical Spine Research Society, we got all the team physicians up on a panel. I don't know if anyone was there, 2020. We had Watkins, we had Dossett, we had all the Cappuccino, all the people that take care of spine on a panel, and we presented the most complicated cases. We had the audience vote 3 times, and then we had the doctor and all that stuff. So this is what we brought together. And these are the questions that I grapple with on a daily basis. Who needs an MRI scan in the first place? Now remember, I told you, every combine athlete gets a cervical spine MRI. But if you have a previous history of having an injury, we all believe the doctors need to see what the preoperative pre-play MRI looks like. We see stingers every game. We go in that little tent that you see on television, we do an examination, and the athletes get smarter. It's like you have a crazy patient that wants spine surgery, they'll tell you they have numbness in their groin and urine incontinence, and they're lying to you. They have a disc herniation you can't even see. It's a lie. Athletes have figured out if they tell you that both their extremities are involved, they're gone. So if they're both, and they want to play, they'll just tell one arm. So they give you the old unilateral story, you examine them and so forth. So a transient stinger with less than 5 minutes of symptoms, we let them go back to play. We don't take an x-ray, we don't do anything. So how do you know they don't have a cervical spine fracture? We don't. How do you know they don't have a massive disc herniation? You don't. If they have symptoms for less than 5 minutes, we let them go back to play. And that was sort of the consensus. Now, you have someone who has a spinal cord injury and has transient quadriparesis on the field, and then they get better, and they have no evidence of myelomalacia, and they do not have absolute stenosis. We let that player go back to play. Now, if you look at all the level 3 and level 4 studies, if you have a 13 millimeter or more canal, you have a less than 5% chance of having a recurrence. If you have a less than 10 millimeter canal, you have a 50% recurrence. We will let that player go back to play as long as he doesn't have myelomalacia. What happens if he gets paralyzed and then he has myelomalacia, and then over time it improves? If he has a normal canal diameter, we let him go back to play between 10 and 13, case by case. And again, this is not science. This is just a bunch of docs getting together saying, what would you do? And remember, everyone's a hero if it's not their case. So remember that. If it's not your case, you're much more liberal and much more aggressive. So this is everyone getting together. Critical stenosis, we do not let them go back to play. Now, what happens if you have someone who gets paralyzed and continues to have myelomalacia? Now, high school, college, you're not even seeing that patient. That patient's not going back to play. Now you're making $50 million and you have no stenosis, but you have myelomalacia. So I voted against this one because I think you got damage in that spinal cord. But 68% of the team doctors would let that player go back to play on a case-to-case if there's no stenosis there. No instability, they would let him go back to play, which I thought was a little bit aggressive. I tend to be, and remember, you become more conservative as you get older. When you're younger, you're less conservative. Now, what happens if you have a fracture and it heals and there's no instability? We'd let them all go back to play. Now, here's another one. If you read all the literature, and there was a literature published out of Northwestern last year in spine that I wrote a letter to the editor. I don't know if you guys read it. Wellington Sue was the senior author. I wrote a long letter. He said it's an absolute contraindication to play if you have a single level posterior cervical fusion. Well, that's not true. You could let a single level posterior cervical fusion go back to play. We let it happen now. We've been doing it in the past. I've done it in the past. So that is not a contraindication. 70% of people say you can go back to play. What happens if you have a cervical spine injury and you have surgery and it's solid, 1 to 2 level fusion, go back to play. 84% of NFL team doctors say 2 level anterior cervical decompression and fusion would let that athlete go back to play. 3 levels, no. The most experienced person on that panel was Robert Watkins Sr., and he said no to this. His son would let him go back to play, which is, I always think is interesting. Asymptomatic patient, you still have myelomalacia, but you do surgery on it, and you have a solid fusion but without stenosis. Over 80% would allow that to go back to play. I'm still on the other side of that. Once I see the damage to the spinal cord, I'm a little bit nervous. I think there's still a risk. Again, I can't prove it. I'm against it, but 80% of the team physicians said you can go back to play. Asymptomatic player who had a corpectomy. Now we're getting, that's a 2-level fusion. Corpectomy, 70% said solid fusion, anterior plate alone, no instability. And remember Hillebrand's paper that looked at the risk of adjacent level degeneration. It's greater with a single level fusion, and it drops with a two level fusion. So it's 2.8% with a single level fusion. It drops down with a two level fusion. So we would let that come back to play. And then a pseudoarthrosis. This is the grappler, and this is the thing that has to protect. This is a medical legal problem. 60% would let a pseudoarthrosis. I would let a pseudoarthrosis go back to play because it means the patient has to go and have a single level posterior cervical fusion. So I sit down, I say, listen, you will have neck pain because you have neck pain anyway. It could get worse. You can get shoulder pain. You may actually develop arm numbness, arm weakness, and paresthesias. But if you're willing to take that risk, we let them go back to play. Now, this is just an example of and this is published by Watkins, and he is allowing his patients to go back to play. NHL player, returned to play at 6.7 months, always has neck pain, has a really bad injury. They get an imaging study. That's what it looks like. Those screws aren't pulling out. He then has a posterior cervical fusion, and he goes back to play. So you can go ahead and do that, and that's not a problem. So many papers done today. When I put this talk together, and there was a case done in Philadelphia on Monday that had an arthroplasty done. So it was 4 up until this point. So it's interesting. Everyone's in the market. And the Player Association was against arthroplasty for the NHL. So and I remember being in debates. I remember getting phone calls and conference. And the Players Association changed their tune after a while. And now the hockey players are demanding if they have a symptomatic disc herniation. So we will know. Next year, we'll know. Because I'm sure if it moves or translates or anything, all of us will figure it out. Now, there's many, many papers that look at the positions that are high risk for injury. What I'm always amazed at, because I stand on the sidelines, a defensive back, they get paralyzed. The second they drop their neck and they hit a defenseless receiver, it's going to be the defensive back that gets paralyzed. But when you see some of these big running backs run up the middle and they put their head down, I mean, you can't get in their way. They just plow you right over. And I'm surprised they're not up there. It's logical to see why an offensive lineman would not have a problem. It's logical to see why a quarterback would have a problem. It's logical to see a defensive end wouldn't have a problem because they're looking up to catch the football. But usually the guys that hit you are the people that have these cervical spine injuries. So in summary, and it's somewhat complicated, I went through every scenario that we see, and I'm sure you have a scenario that you've seen that's perplexing. I think the safest thing you can do as a team physician is to handle this like a team sport. You see something weird, you don't understand it, pull the athlete from play. You get imaging in the stadiums. All the stadiums have imaging, so you can get an imaging right there on the sidelines. It's easy to make the decision if they have a persistent paresthesias, weakness, neck pain. It's complicated when you see someone not moving their arms and legs, and we had the video. You see those little blue iPads we have? We see the play over and over again, and I look closely to see if both arms are moving because they're astute enough now to tell you it's just one arm because they want to go back and play. I mean, they want to go back to play, and they'll put themselves in harm's way. But if the video shows that both arms are not moving or one of their legs aren't moving, we pull them. So very liberal about who can go back to play. The key thing is, keep in mind, if there's relative or absolute stenosis, and you've had a previous cervical spine neuropraxia, you have a 50% chance of that happening again. That takes all high school kids out, that takes all college kids out. A professional athlete will make the decision. But if they have any evidence of myelomalacia, they can't go back to play football. The problem that you'll have is you want your athletes to heal because after you fix them, they're going to feel great and they're going to feel wonderful, and you're going to be really bummed at 6 months you get an X-ray or a CAT scan because you got to get a CAT scan and they're not healed. Then you feel foolish. Then you feel like you let them down. So that's a little trick I do is using autologous bone graft just through a trephine, placing it inside of a polymer cage. I don't use a metallic cage because I want the modulus to be similar to bone. I don't want any stress shielding to occur, and I want it to heal well. So that's my talk, and I want to thank you very much for having me as your speaker. Thank you.